Hi everyone, I'm Jennifer Rizzo, and I am really excited to be here to present my topic on Thoracic Outlet Syndrome, rehabilitation and treatment for the hypersensitive nerves of the upper extremity. This is something that I'm very passionate about and have spent many years researching. I've actually also published a case study on bilateral thoracic outlet and what the difference is between patients and how the same patient can have dramatically different symptoms and results from surgeries. And so it's a really interesting case. And then from that has grown into the passion of trying to find a way to rehab a patient or to be able to provide relief for a patient without irritating the structures and creating an increase in symptoms and an increase of pain post-surgery. I have no conflicts of interest to disclose, and I have no financial relationships to disclose. The objectives of today's presentation is to first to discuss what thoracic outlet syndrome is, how it's diagnosed, how the treatments traditionally look with surgery and with rehab, and then talk about the complexities of treating neurological issues. And this doesn't have to be just for thoracic outlet. I want to focus on that just to be able to define an upper extremity neurological disorder. But the treatments that I'm going to propose can also apply to nerve compressions happening anywhere else in the upper extremity. And then I want to kind of get outside the box a little bit and talk about different ideas of different treatments that we can try to help calm down the neurological system prior to overloading the system with strength and conditioning. Diagnosing and treating neurological disorders is difficult and frustrating for a patient and the clinician. We have to remember that the nerves are all connected in the body. The body doesn't separate the nerves into named branches or give it different names, we do. So when the nerve in the body is irritated, there's a greater chance that the nerve is irritated in a larger area than we think. When we think the nerve may be affected, we need to think system-wide and remember that a treatment away from the irritated nerve could positively or negatively affect the patient's response to the treatments. Location of the nerve will also greatly affect the rehabilitation. The more proximal the nerve injury is to the midline, the more the distal movements may affect that nerve. Just because the pain is localized doesn't mean the movement of the extremity doesn't affect that nerve. Determining if the nerve is compressed at multiple places, such as double crush syndrome, is also a concern. We'll talk more about double crush syndrome a little bit later. Other health conditions may also affect nerves, such as a backed up lymph system, poor blood supply, multiple sclerosis, other neurological issues that a patient might have. With TOS, the higher the fluid buildup or the pressures are in the neck region, this can also create a whole lot of pain and pressure that happen in that area. And so as a result, they'll have more of a hypoxic state due to decreased blood flow and increased stagnation of the lymphatic system. Pain only tells us that there's a problem, but it doesn't tell us what that problem is. Location of pain does not mean that is where the injury is located. We know this when we talk about referred pain. TOS patients often complain of puffiness near the collarbone. This swelling may be from the compressed structures below, but it may also be caused by poor lymphatic movement that's happening in the whole system. Looking at other areas of the body, such as the ankles, to determine if there is system-wide puffiness may help determine if the compression of the tissues is not purely structural, but may also be physiological. Pressure changes cause a bunch of problems, especially in the nervous system. Think about inflamed joints when the barometric pressure changes. Puffiness around the collarbone indicates poor lymphatic flow and may compromise the vagus nerve function. Fluid flow supplies and removes nutrients. We will talk more about the lymphatic system and the vagus nerve at the end of this presentation. Going back to this quote, pain tells us that there is a problem, but the problem could be a bunch of different issues, and we have to go beyond orthopedic and look at this systemically. One of my favorite quotes from Dr. Perry Nicholson is, The human body is under no obligation to make sense to you. Swelling in the neck, tightness in the traps, guarding, inability or lack of wanting to move tissues, numbness and tingling are all symptoms that tell us a story. It is our job as clinicians to think outside the box when a patient isn't responding to a treatment. Are we treating the right thing? If a patient doesn't respond to treatments the way we think they should, then maybe we need to think that there's something different going on. We need to try and figure out where the problem is coming from. This is extremely important with TOS. The symptoms, as we will see soon, can be anywhere from the face down through the arm into the hands and can even involve the scapular region. If we chase the symptoms, we miss the cause. Go beyond asking, when did your pain start? Take a thorough history and see what else the patient tells you. More than likely, pain and symptoms have been happening for a lot longer than the patient comprehends, or the longer the patient has been dealing with this, the more symptoms will have evolved. There is also a compensation that occurs with these symptoms. When one is overloaded, when one system is overloaded, another may be underperforming. The longer a person has been dealing with pain, the more sensitive the person will be. That is extremely important to understand. The longer a person has been dealing with pain, the more sensitive that person will be, which means that there's more systems involved, they're more sensitive, and we have to be extremely careful with how much we overload that system when we start to do our rehab. If you do too many therapies, you could be overloading the system because you are affecting many systems every time you do a treatment. Remember that just because we're treating an orthopedic condition doesn't mean that we're not messing with other systems such as the lymphatic system, the immune system, and then other local tissues. Also remember that our visual and vestibular system, those hold a lot. We know a lot about that with our concussion training. And so the more those systems are also loaded, the more tensions that we get in places like our cervical spine. Cervical spine tension creates muscle tension, which then creates hypoxic tissues, and that decreases our ability to heal. Today I'm talking mostly about thoracic outlet syndrome, but there is a big differential diagnosis of nerve pain in the upper extremity. So there can be a cervical disc issue that's causing the compression, a traction issue, a stinger or burner. You can have ulnar or median nerve entrapment in the wrist or in the elbow, MS. Some TOS patients can get tremors, and so those can also be from multiple sclerosis, so you have to make sure you rule that out. Any peripheral nerve injury, tumors, a shoulder pathology can create upper extremity nerve, and then CRPS. And then you also have to be patient or think about your EDS patients that are super hypermobile. And that hypermobility could be causing muscles to contract. That is creating a forced stability. But that stability is also then causing compression of the nerves, which is causing the neurological symptoms. So a good history does need to happen, and you need to make sure that you rule out, and that's the disadvantage of thoracic outlet. It's more of a rule out syndrome than ruling in. So rule out all the other tumors and injuries prior to giving the diagnosis of TOS. So a quick anatomy reminder of what thoracic outlet syndrome is. We have this triangle right in here. This triangle is comprised of your anterior and middle scalenes and the first rib across the bottom. What runs through there are your neurovascular structures. So you've got your subclavian artery and vein, brachial plexus, and then some abnormalities that could be contributing to TOS can be cervical ribs, which come out of 5 and 6 right in here. And then you have fibrous bands that connect between the anterior and middle scalene that can pinch off the nerve and the blood vessel flow. Um, and then abnormal attachments of the middle and the anterior scalene, either too close together is usually the most common. And then also you see this in some hypertrophy, and especially in your overhead athletes. So looking at the types of TOS, there are 3 types: neurogenic, NTOS, arterial, ATOS, and venous, VTOS. The big difference between the 3 is neurogenic is the most common, and neurogenic doesn't involve any kind of vascular. The reality is, that's by definition, but the reality is if one structure is compressed, all 3 structures are compressed. So how doctors define the difference between something that is vascular versus something that's neuro is a blood clot. So if there's a clot in the artery or the vein, that will define it as arterial or venous. If there is no clot, then they label it as neurogenic. And the symptoms you'll see cross over a lot between the neurogenic and the arterial and venous. But the neurogenic is more broad. And so you can see numbness and tingling in the hands or the arm, pain in the scapular region, medial elbow, wrist, and hand, weakness or atrophy of the hand. And I've also read reports of facial pain, teeth pain, eye pain, and some people have had relief of migraines post-surgery. Arterial and venous will involve swelling of the hand and discoloration. And that's the one that we see and is the easiest to diagnose. And those tend to actually heal the best clinically. All 3 are caused by compression. The diagnostic tools, these vary. There are a couple of thoracic outlet surgeons in the country, in the United States, that specialize in TOS. And they all have different ways of diagnosing. There's the clinical exams that you can do, looking at the symptomology. Some like to do injections into the middle and anterior scalene to basically paralyze those muscles for a couple hours and see if there's symptom reduction, and that will help them make that decision. But every doctor is a little bit different. When you get into the arterial and venous, they'll start to do the Dopplers and ultrasounds just to see if there is blood clots, and if those are found, then they will treat the blood clot and the cause surgically. For NTOS, treatment varies. Most doctors will try to go along the less aggressive route and do physical therapy first, and then go into the surgical route if needed. When we look at thoracic outlets, we need to look at the double crush syndrome. Double crush means that there's a crush happening, a compression of that nerve happening in multiple locations. So there's 4 locations that can happen for thoracic outlet, happening at the C-spine, happening at the pec minor, the elbow, and at the wrist. And so you can have a crush anywhere inside 2 compressions that are happening anywhere in that zone. Anytime that nerve is irritated, it doesn't matter where it's irritated along that path, there's going to be sensitivity down. And the research that I've done over time has also shown that a lot of patients have gone in with carpal tunnel type symptoms, or median nerve type symptoms at the elbow, and had surgery there to start. And the surgery did not fix, maybe temporary, but for the most part did not fix their main problems. And so then they continued to work their way up the arm until they got up to the neck and found either disc pathology or ruled it as TOS. And then those patients, unfortunately, because of the amount of irritation that's happened on those nerves, they don't respond as well to surgery. But some have found that treating the compression at the thoracic triangle will help their distal wrist pain that they didn't get any treatment with, or didn't have any symptom reduction with after their compression release surgeries. So 95% of cases are NTOS, while 4% are VTOS and 1% is ATOS. You also have what's called pec minor syndrome, and that is that other location of compression underneath the pec minor. TOS is very difficult to diagnose. It is still listed in the rare disorder category, and there's a lot of controversy with how to diagnose. And so a lot of patients have it missed for a very long time, and as a result, a lot of NTOS patients go years with this compression happening, improper treatment, which then at the end leads to a decreased insatisfaction post-surgery and reduction of symptoms. There's a lot of different presentations of symptoms. So in my case, my right arm versus my left arm were completely different set of symptoms. My right arm, all my pain was in my hand. I didn't have any shoulder pain, neck pain, anything like that. After my first surgery, my symptoms on my left side are all scapular symptoms. After my first surgery on my right side, I actually woke up and realized that my ear didn't hurt anymore and my teeth didn't hurt anymore. And so I had been complaining to the dentist that I had a couple teeth that were really bothering me. And every time I went in, they told me that there was nothing wrong. One of them I had a root canal on and it still hurt. The dentist said it should not hurt because there's no nerve there, but it still continued to hurt. And so that differing of symptoms, a bunch of patients are going to present with all these different symptoms, and it makes it very difficult to diagnose. Surgical interventions are complex. Surgery involves removal of the first rib and the scalenes. You're dealing with nerves and blood vessels, and so there's a lot more risk in that region as well. And then diagnosis, because the diagnosis is difficult, so is the rehabilitation. So here are some of the diagnostic tools that we use. The DASH score is looking at symptoms of the hand. They'll usually do this leading into physical therapy, throughout physical therapy, pre-surgery and post-surgery. And then that DASH score will hopefully improve throughout the course of rehabilitation. MRI and MRA, both are very inconclusive and do not show actual compressions. And so a lot of times patients will go in and have a negative MRI, barring that they don't have any disc involvement. And so then they get frustrated. And so the doctors say there's nothing wrong, but there's still a compression that happened in there. And when we look at our diagnostic tests, such as Ruse and Allen's test, all those happen with the arm above the head, and an MRI exam is done with the arms at their side, so you wouldn't see that compression. X-rays will show if there's an extra cervical rib. EMGs can show if there is some kind of degeneration happening in the hand or the forearm. And then the scalene and pec block. This seems to be growing and is more common for surgeons to be using to determine if they want to do surgery or not. And then you have to look at the artery and the vein to see if there's any compression happening there. And then clinical exams, we find that a lot of patients will present as positive in their clinical exam but have no symptoms. And so most doctors don't use the special tests of Addison's, Allen's, military, or Ruse. So our treatment options, surgical options include scalenectomy, which is removing the anterior and middle scalene as far proximal as they can. First rib removal, they take that first rib completely out. This is a different technique that different doctors use. Some doctors prefer not to remove the entire rib and only remove sections of the rib. And there are case studies out there of those ribs actually growing back and then causing even more issues in the long run. So they have found that most patients that have first rib removal do best removing the entire rib and are less likely to have to go in and have a second surgery to clean up bone fragments and scar tissue that's formed in there. Cervical rib removal. So if there is that extra cervical rib, they'll go in and take that out. And then the pec minor release is releasing that pec minor to release the tension on the nerve as it goes underneath. Non-surgical options: physical therapy, chiropractic care, acupuncture, Botox injections into the anterior and middle scalene. That basically mimics that scalene block where they relax that muscle, paralyze that muscle, and so there's less compression. And then trigger point injections as well, and you'll see that in the trap, scapular region, and in the scalenes. Our long-term outcomes for neurologic surgery for TOS. Again, the neurological symptoms have less favorable outcomes. Arterial and venous, because you see the actual compression occurring with the blood clot, those are actually tend to be more successful. And those surgeries, there's actually 2 surgeries that happen. The first is to remove that first rib and to remove the scalenes, remove that compression. And the second, they actually need to go in and remove that blood clot. So you'll have 2 surgeries for someone that has arterial and venous thoracic outlet. So the long-term outcomes of NTOS, the sooner the person is diagnosed and has surgery, the better the outcomes. The longer they wait, the worse off. So if you have surgery within the first 3 months of forming symptoms, those patients tend to have the best outcomes. 18% complain of permanent disability, inability to use the hand at all or the arm, like permanent muscle atrophy, pain, inability to go back to work. 59 to 88% of conservative treatments were successful, and that is why most doctors want to start with the conservative treatments before they go into surgical. 65% of patients were satisfied with the outcomes of surgery. 90% reported improvement in symptoms. 66% complained of long-term symptoms, and 75% were able to return back to work in full time. So when you look at these numbers, this isn't great outcomes for the success of the surgery. And so starting with that conservative approach is your better option. But when surgery is in there, we obviously need to find a different solution or a different way to help these patients with these long-term symptoms that they have, regardless if they have surgery or not. I really like this quote: "Tissues heal, but the nervous system remembers. Sometimes pain can persist as a result of sensitivity and not tissue damage." So one of the biggest pet peeves of patients is when they walk into a doctor's office and the doctor says, "It's all in your head." False. It's not all in their head. Yes, pain is subjective, and yes, every person experiences something a little bit different, but it's not just false information that they're creating that's sitting in their head. They actually have a symptom. They actually have pain. And so we have to dig a little bit deeper into understanding what's happening within that nervous system beyond just the injury itself. So the tissues were injured. There was a surgery. Eventually that surgery and those tissues healed. But that chronic pain that continues on, where is that coming from? And so we have to figure out why those nerves can't relax. And so we can look at the system from the neocortex and the prefrontal cortex, the limbic system, and the brainstem. All 3 systems work together. The neocortex sees what it can learn about the environment, so it's looking to see what's around us. The limbic system holds on to emotions and memories from the past and the present and current events. And then the brainstem determines if the body is in a safe position. And so all three of those systems have to work together, but they all have to be in this happy place in order for the body to say, oh, I'm no longer being attacked. I'm no longer in fear. And so we have to figure out how to calm that system down. And so if a patient comes into treatment and they're in pain, and part of that treatment increases their pain. So the massage is painful. Sometimes you got to get in there and break knots up, but if they feel that threat, then the system is going to respond to that threat. And instead of healing, it's going to put on the brakes and say protection, protection. And so now we're not only trying to treat the system, but we're actually creating even more fight or flight and throwing them into this sympathetic response when we're actually trying to calm them down. Cells are either in growth mode or defense mode. They can't be both at the same time, and you cannot heal when you are defending. So we can't heal in the same environment that we got injured in, right? So we can't expect a nerve to heal if it's still being compressed. So we do have to deal with that compression. We have to figure out what is causing the compression. We do have to deal with that. But if the system is in this defense mode, again, it's not going to be able to heal because it's constantly fighting. We have to calm down the nervous system first. That is the number one thing that we have to do in treatment, is to calm down the system. And we've got to calm down the system, the entire system, not just the TOS pain, not just the nerve referrals that are occurring, but the entire system. We have to remember that the longer the nerves have been suffering, the less energy they can tolerate. So if someone comes in and they've been in pain for 2, 3, 4 years, whatever it is, the longer they've been in pain, the longer or the harder it is for their system to relax and to trust. And if they've been in pain that long, you're probably not the first person that they've come to for this pain. And so they're going to put the brakes on real fast and be super skeptical. So we have to remember that those nerves can't tolerate much. Therapeutic interventions are stressors to the system. We're treating the entire system. We're not just treating the TOS, we're treating the entire system. And any therapeutic intervention we do, even if it's meant to be relaxing, is still a stressor to the system. So we have to be very careful not to overtreat. Lack of blood flow and the lymphatic stagnation both cause hypoxia, which is decreased oxygen to the system. And so as a result, that hypoxic system is going to create cell death, which is going to decrease that synaptic activity, which is again going to create nerves that are hypersensitive and not able to react, are going to create muscles that can't heal because they don't have enough nutrients. And so we've got to work, I've talked about lymphatic flow already, we've got to work on that lymphatic flow and that blood flow to get everything in the whole body moving and get those nutrients where we need them. We also have to be careful with patients that have blood sugar issues because their system isn't able to, they get more fatigued quicker and the nerves are a lot more hypersensitive. So we need to encourage patients prior to treatment to come in and have controlled their blood sugars or be within those good ranges during their treatment. Too many therapies will overload an already sensitive system. We cannot forget that this system it's overload. The patient can't handle much more physically, psychologically, emotionally. They can't handle it. They're in a lot of pain. So we can't continue to overload their system. But we have to remember that something like STEM could actually be too much for their system. And so we want to figure out a way to create that lymphatic flow, that blood flow, without actually irritating that system that is feeling overloaded. We need to assess the entire system. We need to look at the diaphragm. Is the diaphragm working efficiently? Remember, when people are in pain, they tend to hold their breath, especially when the pain is the neck and the arm region. And so they change their breathing patterns. And so they're no longer diaphragm breathing. They're now chest breathing. They tend to hold their breath a lot. they tend to fall into that like preservation posture, that rounded chest, like sunken in chest, rounded shoulders. That is all a posture to help protect. And so we want to really work, make sure that the diaphragm is working efficiently. And what's happening with their organs. I know as athletic trainers, we don't talk about visceral organs a lot other than the injury that occurs to them. But the organs move in the system because the diaphragm moves. The diaphragm of that pelvic floor is like an accordion, and they're constantly moving those organs around. And if someone has been chest breathing, they haven't been moving those organs efficiently. And so maybe we need to get in there and do some mobilizations to the kidney, the liver, the spleen to try and get things moving around so that diaphragm can actually move. And that might actually decrease that sympathetic response. And then it could also decrease pain. The more health issues a person has, the more relevant simplification becomes. So we don't want to throw the textbook at someone when they come in with thoracic outlet. We want to start off slow. We want to treat maybe just one thing at a time. And I will tell a patient, I do not expect a big change. I do not want a big change in these first couple sessions. I want to build a trust that the person has with me, that their body has with me. I want them to know that they are walking into an environment that I can treat them. And when they leave, they are no worse off than when they came in. Unfortunately, there's no black or white way of doing any kind of treatment. And we know this for any injury down to an ankle sprain. But we want to start off small, and we want to start off with little movement, little treatments that can be powerful, but that don't set off the system and that the patient may not feel a lot of, and that will help build that trust as they work with you. And we also want to make sure that we're solving the right problem. And so again, going back to that history, we know that the person has thoracic outlet syndrome, but what else is going on? What else has been affected in their time with this pain, with these symptoms? What other systems are involved? Can we start treating a different system first with the hope that that positively affects the TOS? And how do we look at that patient in just a broad perspective? The diaphragm plays a big role in upper extremity injuries, especially in thoracic outlet. The longer a person has been in pain, the more tense that diaphragm and the rib cage becomes. And so it's really important to teach the patient proper breathing techniques, how to utilize the diaphragm. But what is the role of the diaphragm? The diaphragm helps move organs. So every time we take that deep breath in, the diaphragm pulls down. As the diaphragm comes down, it pushes all of our internal organs down. And then as we exhale, that diaphragm comes back up. When it comes up, the organs release and come back up. The organs are constantly moving up and down, up and down. The other role that the diaphragm plays is to influence the vagus nerve, and the phrenic nerve also attaches to the diaphragm. So those are two big, powerful nerves that run down the neck, by the sternocleidomastoid, underneath the collarbone, and down into that diaphragm. If we can treat the vagus nerve and the phrenic nerve through just diaphragm breathing, we might positively affect the pain symptoms that a person is feeling up in the neck without actually touching the neck. When the diaphragm is tense, the result is poor breathing patterns. It results in tightness in the upper traps, and tensions, and then don't forget the hypoxic nature of muscles. If we're not pulling in enough oxygen, we're going to create a hypoxic nature. Diaphragm breathing and diaphragm mobilizations can also both help with shoulder pain. And so we can treat, without treating TOS, we can actually treat if there's an underlying shoulder issue. We can also treat that through helping teach the patient how to breathe. So these are two techniques that I use. I just pulled these pictures off of, or three techniques. I pulled these pictures off of Google. The first one is a diaphragm release, where the patient, I actually like to use a large Swiss ball and have them just lay on the ball and then practice barrel breathing. And so they take, basically I want them to push their belly in and to the side as they take deep breaths, and expand breathing with their stomach using the ball as the resistance. And so if it's hard for them to breathe into the ball, then they're doing it correctly. They can also lay on the smaller ball and just do a release. And as you can tell, that's also moving around some of the organs in there. So you got a double whammy there. Laying on the back, putting the hands on the stomach. This is a traditional belly breathing techniques and practices. So I teach this to any of my patients that have upper extremity neurological issues. And then the last one is I did take a course on organs and kind of how to mobilize them. And so I do organ mobilization as well in my office, just to visceral organs, just to get everything moving, encourage that movement. And I find that there's a lot of power that comes through moving the organs around. We get lymphatic flow happening, the organs in a better spot, the ligaments of the organs are happier because there's no longer extra tension on them. And so there's a lot of benefit of moving everything around in the belly. The vagus nerve, I love this picture because it just amplifies the vagus nerve, how it comes out behind. So it's cranial nerve 10, comes out behind the ear, runs down along the sternocleidomastoid, underneath the clavicle, and down into the stomach. And so that vagus nerve affects lungs, it affects your gut. So the motor functions of the vagus nerve is heart, lungs, brachii, and GI tract. And the sensory is heart, lungs, brachii, trachea, larynx, pharynx, GI, and external ear. So anytime we're trying to positively affect that vagus nerve, which will be negatively affected with thoracic outlet, because if it's running along that line, if there is any surgery that occurs to the anterior middle scalene, that vagus nerve is going to be affected. If there is any compression happening anywhere in that neck, that vagus nerve is going to be affected. And so we can utilize the sensories, heart, lungs, not so much, but we can get in and do some trachea work. We can work on the external ear, and those will all create positive patterns that will help take that person out of that sympathetic and pull them into that parasympathetic response, pull them out of that fight or flight response. Imbalances of the autonomic nervous system provoke high and low blood pressure. So a patient that comes in that's struggling with their blood pressure, either too high or too low, they might be in that constant fight or flight. Tissue tightness, which we see all the time with TOS patients, sympathetic dominance, system inflammation. So we're not just talking nerve pain, but they also have a chronic knee issue. They have maybe an autoimmune disorder, anything like that, where the system is in this high inflammatory state. That is all part of this autonomic nervous system that is just there in just sympathetic dominance. A complaint for TOS patients is that blood pressure changes in the affected arm at different points of the day. And it also can be different from the affected arm versus the non-affected arm. And so if those are happening, then you can guess that that vagus nerve is somehow affected. So chicken versus the egg, what has caused the muscle tightness and the guarding? Is it the vagus nerve? Is it the muscle? Is it the brachial plexus that's been affected? What is the chicken? We don't know. But I will always start by treating the nervous system first and trying to calm that down. And then also trying to get the person out of that sympathetic response. But we have to remember that we can't over-treat. And so you can give the patient one or two things to do at home to try on their own to see if they can calm down their system. So things like a cold shower or splashing cold water on their face to calm them down. A neck massage, especially around, and this could be really light. This does not need to be hard by any means, but a neck massage to calm down that vagus nerve. Humming stimulates the vagus nerve. And then a sternum release. So here's a picture of releasing the sternum. We're not talking a chiropractic adjustment. We're basically talking putting the fingers on the skin and sliding the skin over the sternum. There should not be any pain when we touch the sternum. We should be able to lightly move the skin back and forth and create that tension on the skin without creating a major pain response. We're not trying to overstimulate that. This is just a real passive movement. And I have been doing sternum releases. I do them on all my shoulder patients. And I don't do it from a neurological perspective, but I just do it because everything's connected to the shoulder. Pec minor, pec major all attach in the same spot. And so if I can work that sternum, that's going to help release some of the tissues of the shoulder. And then I also found that by doing that, it also helps with that vagus nerve. And so then I can release some of the tensions that are occurring neurologically. You can also do a light massage above and below the clavicle. You'll find that a lot of TOS patients will have pockets of swelling in that area, and that is probably more than likely lymphatic blockage, or just the pressure of the lymphatic system is sitting right there. So doing a light massage, again, it's not deep tissue. A light massage above and below the collarbone will also activate the lymphatic system and will help stimulate that vagus nerve. Massage behind the ear. So from the ear, following down the sterno, down where it attaches to the collarbone, that is going to be a great path to follow to help stimulate that vagus nerve as well. And then another stimulation of the vagus nerve is massaging the external ear. And so just having, like, anytime that person feels like they're in this like hyper anxiety moment, they can massage the outside of their ear, the external ear, and that will help decrease the sympathetic system as well. One thing that I don't do very often, but it was a technique that I learned, was grabbing someone's trachea lightly. Obviously, we're not trying to choke them out, and just shifting it back and forth. The trachea should move. It's a movable part. And so we can see when people try and turn their head right or left, if there's any adhesions there, that trachea is going to limit cervical movement. And so getting in and grabbing the trachea and moving it side to side can help also release without creating a big movement. But just be careful, because people that have had traumas, you don't know what physical or psychological traumas people have had, that can create a lot. So that is one I am careful with, and make sure you ask before grabbing anyone's trachea. Other things that you can do to help positively affect the vagus nerve without overstimulating the other symptoms. I mentioned humming, working on the proper breathing techniques, grounding, being in the sun, cold water to the face, a cold shower, smiling, and just flat out being in nature. So blood flow and lymphatic flow, extremely important when we're talking about the entire system, but especially in thoracic outlet. But you do have to be careful with blood flow, especially someone that is ATOS and VTOS. Because they've had a clot, you have to be very careful with what you can do. And so I would have the patients, or you ask the doctor what is okay as far as blood flow work that you can do for them. And we really want to think about it this way: is there's a balance between having too much blood flow and too much oxygen and not enough. And so we want to find that balance. And what we can see in some patients is we might have increased blood flow to one side and decreased to the other. And both, it doesn't have to be that the decreased side actually has pain or no pain. So we have to find that balance. And you can do this by taking pulses. Look at the pulse, the wrist pulse. Do they have a decreased pulse? What is their cap refill? Anywhere on the arm, is the cap refill the same on the right versus the left? And if one is faster or slower than the other, then we need to think about how we can positively influence that blood flow to balance it out from the right to left side. So increased tension equals decreased blood flow, which equals increased pain. So when we have a patient that comes in that has been in pain for a long time, they carry their tension in their traps, they squeeze their shoulders, they bring their shoulders up towards their ears, and as a result, they're decreasing the blood flow, and they're gonna affect negatively the nerves that are in that region. And so we have to figure out how to decrease the tension, which will then increase the blood flow, which will then decrease the pain. In all serious disease states, we find a concomitant low oxygen state. Low oxygen in the body tissues is a sure indicator of disease. Hypoxia, or lack of oxygen in the tissues, is the fundamental cause for all degenerative diseases. Oxygen is, of course, the source of life to all cells. And so when we're looking at this hypoxic nature, blood flow is super important. And so we have to work on the blood and lymphatic flow to make sure that we're getting nutrients in and waste out. But we want to, again, make sure that we're not overloading the system with too much blood flow, because too much is not good either. So we want to find that balance of having the right amount of blood flow to help increase nutrients, to help increase healing, but not overload the system. When the blood and lymphatics flow freely, the tissues can perform their physiological functions without impedance. With the occurrence of trauma, physical or emotional, the tissues contract, twist, and compress. The fluid flow becomes obstructed. So it is super important, again, another example, and this is from Dr. Andrew Taylor Still, that we look at what's happening with blood flow and lymphatics, and we really see how it's affecting the tissues. And it's not just the tissues at the location of the compression. We know that there's a compression happening between the anterior and middle scalene, but what's happening below that? What's happening distal to that? How do we increase blood flow despite having that contraction? How do we increase blood flow without irritating those nerves? Those are all part of this process of learning how to treat a patient without setting off their system. So, redid that slide to increase tension equals decreased blood flow, which equals increased hypoxia, which equals increased pain. So that is basically what we're trying to create, is the perfect fluid flow between lymphatics, between blood flow, and then by decreasing tension on the nerves, increasing the amount of oxygen within the system, we can find a happier place and way for the system to heal. So when we look at lymphatics, there's major points in the system where we can promote lymphatic drainage. A thing to remember is if we have someone that has swelling in their ankle, that swelling is not just affected by the lymphatic flow of the ankle. It's the ankle, the knee, the groin, and the stomach. But then we can't just stop there. So really, when we do a lymphatic release or we have chronic swelling, we want to do a release of the entire system, which would include cervical, axillary in the armpit, stomach, groin, behind the knee, and the ankle. And so we want to do tapping, light massage or rubbing Those are all techniques that will help with moving the lymphatic around, vibration. Not necessarily the percussion gun it will work, but more like the vibration of like the vibrating foam roll. That would be a great tool to use to increase lymphatic movement. Because remember, the lymphatic system doesn't move on its own. We have to create that movement. Asking someone to move their body will also increase lymphatic flow. So if you have someone that hasn't moved their arm in a long time because of pain or because of fear of pain, that will happen as a result of movement. We need to encourage that movement to occur. And if it can't, then using something like the vibration ball, if they can handle that much, can help move that lymphatic system around. And if they can't handle that, then we got to work everywhere else in the system to get the lymphatic moving. And as that lymph starts moving, then we can hopefully start to get closer and closer to the affected side. One thing that I see with TOS patients is they don't like to move. They don't want to move the arm. And it's not necessarily that the pain is the immediate pain of the movement. It's the repercussion of the movement. So today, a patient went in and they cleaned their bathroom, but tomorrow they can't move at all because they're in 9 out of 10 pain. And so they have this extreme fear of movement, so they don't move. The other issue that causes a lot of these chronic conditions is too much movement of the same kind. And so we want to be creative with how we move a patient, not forcing the same movement over and over again, but staying within that functional range of what they're comfortable with and pushing that range every time we see them, if we can, but encouraging different types of movements that mix things up. And so that way the body just doesn't create these overuse of the same movement, but then we also move the body. Things that we can do in treatments that don't involve the upper extremity, but are movements of the body would be calf pumping. I call it walking with a purpose, where it's like very defined walking. So they swing the arm and the leg together. Tapping or slapping of the body and the collarbone. We actually see this a lot in Asia, where they just tap different body parts. And so that's going to create that lymphatic flow, to be honest. And then any movement of the lower extremity is going to positively affect the upper extremity. So if a patient can't move their arm for whatever reason because that pain is too much, then start with lower extremity movements first and show them that they can move without pain. Teach the brain that that's okay, and then move into introducing new movements of the upper extremity. So the hardest part about writing this presentation was I want to share with you how to help a person, but you can't create a black and white treatment plan. There is no black and white treatment plan. We know that for the entire body, but it's even more so when we talk about neurological, because the neurological system is so sensitive. But again, every person is so different and they respond so differently to treatment that I can't give you a black and white treatment plan that's going to help. And so I'm going to give you a bunch of different things, and I hope throughout this presentation there's been little snippets of things that you can try with your patients. And the thing is that we don't know until we try. And so you're going to try a treatment plan, and you never have the intention of making someone feel worse. You always have the intention of making them feel better, but sometimes nothing happens, and sometimes you make them worse. And so having that communication with them and say, you know what, if I made you worse in any way, you have to tell me so we can start off slower. Sometimes we just don't know what is too slow and what is too much for a patient until we try something. And a hypersensitive system is not the time to be aggressive. So put everything else aside and start out with really slow movements. Start out with really passive treatments. Treat the sensitive system, get that under control, and then add in the rest of the treatments. So do not cause pain. Don't put that patient in any more fight or flight than they already are from daily life. So no treatment that causes pain. Work the tissues of the sternum and around the collarbones, again promoting lymphatic flow, and then that also stays away from the spots that hurt. Diaphragm release and teaching a patient how to breathe properly. Light massage along the sternocleidomastoid to promote that vagus nerve. Light, pain-free movement of the arm and the neck, but if they're not able to do so, then start with the thoracic and the lumbar spine down into the legs. Organ massage release, especially around the liver to free up the space for the diaphragm to move more efficiently. Lymphatic drainage, and there are hundreds and thousands of YouTube videos of different lymphatic drainage techniques. And I just recommend going on and looking at videos and just figuring out what one you like the best, or combining the different techniques and seeing how they can positively affect your patients. And then we always know that we have to add in strength training and how important that is. And if a system hasn't been used, those muscles have atrophied greatly. And some of that is just from disuse, not necessarily from the neurological piece. And so adding that strength training back in when the system is able to accept that load. So I hope you have enjoyed this presentation. I hope you have learned something about thoracic outlet syndrome and treating neurological disorders of not just TOS, but also of the upper extremity. These are some outside the box techniques that I like to use, and that I encourage you to investigate and find the techniques that work best for you and your patients.